There we go. Good afternoon, everyone, and welcome to another FACE seminar. My name is Clint Hendrikse. I'm the head of division of emergency medicine at UCT. And it gives me great pleasure to announce our speaker today, Dr. Willem Stassen. He started out as a pre-hospital provider, became an academic, and now he's the convener of the PhD program at the Division of Emergency Medicine at UCT. And he's got many hats. He's got an extensive research profile and academic profile, both internationally and nationally. And the topic that he's addressing today is, in their own voice, an approach to developing telephone triage systems. So essentially, without giving much away, we know that the ambulance services in low and middle income countries is a scarce resource, but we also know that the demand for it is quite high. And it is important to bridge that gap. Before I hand over, just a reminder, for CPD points, please email Jeroen Swart. He will post his email in the chat if you require CPD points. Over to you, Willem, and thank you very much.
Thank you, everyone. I'm just going to switch off and thanks for the introduction, Clint. I'm just quickly going to switch off my camera so that I don't have to deal with all the technological things at once, trying to figure out what to do here. And then I'm just going to go ahead and share my screen, which you should be able to see in a moment. Right. I'm assuming you can see my screen, right, Clint?
We can. Thank you, Vin.
Oh, thanks, June. Cool. Okay. So I'm going to be chatting about the development of telephone triage systems, specifically with reference to some of the work we've done in the South African context. But hopefully by the end of the discussion, I will be able to convince you that this is a good idea, and that you would support us in the work that we're doing in developing these. So as Clint said, I'm Willem Stassen, come from a background as an emergency care practitioner working clinically in Johannesburg. And then just before I moved on to Cape Town, I was in the contact center of a private service. And that's where this, shall I say, passion for telephone triage actually started. So just by way of disclosure, most of the studies that I'm going to be talking about today were actually funded by a Tutuka Fellowship of the National Research Foundation of South Africa that was awarded to me as principal investigator. So first off, the question is, what really is telephone triage? Well, very simply, it is the process of, based on information provided by a caller to a call taker or emergency dispatcher, and through that conversation to then really evaluate whether an emergency medical service response is needed or warranted, and if so, at what priority should that response be launched, and especially in context where there are different cadres of pre-hospital provider that have differing scopes of practice, we're also asking at this point which unit to send in order to be able to provide the maximal impact towards mortality and morbidity, given their skill set, given their baseline education, and given the needs of the patient. Now, important to remember is that all of this really occurs only through, for the most part, verbal exchange of information between a call taker and a caller who is on the scene of, probably on the scene of where the emergency is occurring. And telephone triage can sort of occur in two types broadly. The first is sort of a medical priority dispatch, where a series of questions are actually administered by the call taker to try and elicit information and bolster the accuracy of the decision that they are making in this when they are deciding on the priority and which unit to send and whether emergency response is warranted in the first place. The other one is sort of based on what they call criteria dispatch in the Scandinavian spaces. And that relies wholly almost on the experience of the call taker to be able to accurately assess the situation based on intuition or experience or some other kind of criteria that they're using to make a decision as to whether this is what the situation is and what the warranted response would be. So why would we then say is telephone triage actually important? I think firstly, as what Clint said earlier, is that there are limited resources. And no matter where you go in the world, whether you're in a high income context or in a low income context, the point is that there is always a finite amount of resources available at any one time. And especially in low middle income country contexts where, like in South Africa, for instance, where we have a bit more of a fragmented emergency medical service of private services, mostly serving their clients, public services serving everybody, and a mixture in between. Sending a priority response to one case almost immediately means that another would need to wait, especially in contexts or in instances where there's a mismatch between the utilization rate of the ambulance service and what exactly is available within the system in order to support these responses. Now, this may also have quite an impact on patient outcome, both in terms of just acceptability and satisfaction with the service that's being provided, but also very much on the sharp end, actually on outcome of the patient. So if a call is erroneously seen as low priority, but it's actually high priority, that could actually have an impact on the patient's life. It can also have an impact on the way that the service is perceived, reliability as it relates to response times and so on. Furthermore, in emergency care systems, as I said earlier, where there are different cadres of EMS, sending the incorrect cadre or a cadre of an inappropriate level may actually delay certain interventions. I'm thinking about a context where only a certain cadre can actually administer pain medication, for instance, in which case if an inappropriate level of pre-hospital provider goes out to that scene, they would need to call for backup, so to speak, in order to provide a particular intervention. Similarly, where it comes to diagnostic decisions or decisions of referral pathwaying and so on, this becomes important. But the opposite is also true, especially in contexts where there's really low resources, which is basically everywhere. This can also lead to waste. So if you send the highest cadre of provider where there's often less of, to cases where this is not warranted, that could lead to wastage. And of course, that means that places where that person is required will not have that response. And then we also need to think about the greater societal impact of an inappropriate lights and sirens response. So we know that driving with lights and sirens on and driving faster in a sort of response driving process actually places the lives of crew and other road users in danger, because of course it can lead to accidents, and it would make it inappropriate to launch a lights and sirens response if we have certainty that this is not actually justified. So all of these things are really considerations, both system and patient level at the sharp end considerations, as to why telephone triage is important. So when we look at accuracy of telephone triage, Kurland, my actual, I was going to say old PhD supervisor, but she's not old. It's just she used to be my PhD supervisor. This was not my PhD topic, but Kurland and Katarina Bohm, Lisa Kurland is the first author who was my supervisor. They performed a systematic review and published it in 2018, where they looked at the accuracy of a series of different triage telephone triage tools and algorithms and systems. And they found low to very low levels of quality of evidence that looked at triage accuracy and dispatch, often reported in many different ways. And over triage ranged from 71 to 78%, which is about, like 4 out of 5 over triage rates, and under triage rates ranged from 3 to 4.5%. Now, just to remind you that over triage is an instance where the acuity or importance or gravity of the case or priority of the case is sort of placed at a higher level than what is actually required. So it is overestimated. And that leads to potential resource waste. Under triage, on the other hand, is when we underestimate the acuity or the danger or the priority of the case. And that could almost certainly have a sharp end patient outcome focus. So you want to tend to strike the balance between over triage and under triage rates. Importantly, though, that Kurland and Bohm found that all of the studies that were included in this systematic review, barring one study from Iran, all originated from higher income country settings. So the question then is, are these results actually transferable? So the results of the systematic review, can we transfer these results to low middle income country settings or instances where we have pluralist health systems like in South Africa? And I would argue no. Notwithstanding, we always say, oh, but that's not really from a setting that is relatable to what we do and what we have. There are other considerations that we need to think about. Now, I fully take on the point that certain private sector emergency medical services could be quite comparable to what we see in higher income countries, and it might actually be in some instances more resource than what we see in high income country settings. So notwithstanding that point that we can agree upon as a departure point, I argue no, that these results are not transferable. Firstly, because triage systems in high income countries often have established processes, criteria, and so on that's already embedded in their very centrally controlled emergency dispatch and call center and call centers. So because of that established process versus the nascent processes within low middle income countries, especially with only emerging emergency medical services processes, this is not transferable. Also, there are standardized training opportunities and courses and curricula of dispatchers and call takers in high income country settings, which also makes these results probably not transferable. In high income countries, there is also generally more resources available. So it could be justifiable to err on the side of rather high over triage rates, so that because there's a little bit more resource to expend there, and then, balance out having rather low under triage rates to improve patient safety. Then, of course, because there's a different epidemiology and burden of disease in these contexts, they can focus on other, maybe bolstering the accuracy of certain things like out of hospital cardiac arrest, but also because the epidemiology is different, the pretest probability of, the accuracy of what we're going to be looking at is also different than what we have, and therefore also baseline accuracy would be different because of those differences in epidemiology and burden of disease. Also often, in many high-income countries, there is often a single language that is spoken in this country, and there's generally high levels of baseline literacy. That's not the case in multicultural settings or in settings where there's quite a lot of migration and many different compounding vulnerabilities of the person who is seeking emergency care. And that also might influence, especially because language is so seated in culture and often in the way we can express ourselves is often, especially in a language that's not our own, is related to literacy. That could influence the accuracy, and therefore those results are not transferable once again. And as I said, the selections of the descriptors are really seated in the information that the caller provides. So they say what's happening, what they're seeing, and so on. And they therefore often use important colloquialisms or sociocultural aspects that international criteria cannot really provide for within other contexts. And therefore, we can't just simply translate English criteria into other languages, because that might necessarily not be seated in the socio-linguistic cultures that exist within different contexts. So this means that we have to reconsider the way we develop these algorithms, either adapting them, refining them, or developing them from scratch, because these results are not transferable for the reasons I cited. So maybe just to quickly look at what happens on the ground, as in what do we see in the South African context, and this is in the Western Cape in particular, around the accuracy of telephone triage. Well, this is firstly just to say what happens on scene, and this is a paper by one of my PhD students who we actually published it this year. And this was a retrospective cross-sectional study of 245,000 ambulance responses in the Western Cape. And we found that in 83% of all of these responses, there was absolutely no medical intervention provided in the pre-hospital context. So that's quite a lot of instances where an ambulance response goes out to a patient, but where they did not actually, well, whether there was no intervention because of error, or whether there was no intervention because of genuine not having a need for it, that we haven't established yet. But this draws us to needing to look for more evidence around this. But it seems to be a mismatch between the requirement and the ambulance response. Here we looked also at non-transport, so instances where the patient either refused to go to hospital or refused to be refused transport, because this is one of the only ways we can at the moment establish non-transport versus whether the patient truly is low acuity and does not require hospital or emergency center care. We found that the call types or incident types that's most predictive of non-transport included diabetes and motor vehicle collisions. And when treatment was provided on scene, we found that the treatments that were most predictive of then staying at home was nebulization and the administration of glucose. And while I'm speculating here, that looks a lot to me like instances where chronic conditions are not well managed, and or access to more general primary care is not actually available, probably due to limited transport that's available, public transport and so on, and speaks about barriers to access of care. And that might be something we can unpack to see how the burden can be dealt with in future work, but that's not related to telephone triage at the moment. But there's certainly a mismatch between a emergency response and what is required of the patient in this sample of many, many, many patients. And there's another paper published by Newton and team from the KwaZulu-Natal context that finds similar, I think there it was in the 60s, of instances where patients received no medical treatment despite an ambulance response. In unpublished data, specifically looking at triage category, or triage accuracy, sorry, but in the same data set, we found over triage rates of 62% in our context, and under triage rates of 15% in the Western Cape. The current triage process has a sensitivity to rule out of 54% and a specificity of 74%. We found the highest over triage rates in obstetrics at 89% and gynecological complaints of 86%. And then abdominal pain and vomiting and diarrhea had over triage rates of about 75% each. And the highest rate of under triage, where we underestimate the acuity of the patient, was in instances of respiratory complaints at 31%, and strangely enough, chest pain also at around 30%, diabetes at around 30%. And in patients where there was no response, or an unconscious patient, unresponsive patients, shall I say, we found under triage rates of 27%. So there's certainly certain incident types where we have really high over and under triage rates, which results in wastage of resources, but also results in potentially harm to patients. So there is something that we need to, there's some clues that we need to start addressing this in some way. So given that these contextual, linguistic, and colloquial factors can influence the accuracy with which we can perform telephonic triage, we then embarked on a series of studies to understand the telephonic triage landscape within South Africa. And we basically started working on out-of-hospital cardiac arrest, myocardial infarction, stroke, and sepsis, as these are quite important emergency presentations that the influence of EMS can actually make quite a big difference. And they have very specific diagnostic criteria, which we were able to apply, although I can also accept the argument that sepsis does not. And then we sought to determine, as a starting point, how callers described each of these in different languages, South African languages. So here's some of the evidence. Now, I have to say, when I started working on these descriptive things, I didn't actually know where I was going to go. So you are going through the journey of this talk. You're going through basically what we developed as we started seeing things coming out of the research. So let's quickly see what the evidence then shows. So what we did in all of these instances is we would take the ambulance diagnosis of myocardial infarctions, the sepsis, or out-of-hospital cardiac arrest based on a diagnostic criteria that we either applied to vital signs or to ECG findings or so on. And we then took random samples of the original voice recordings of those cases where there was positive MI or sepsis according to the screening criteria, or out-of-hospital cardiac arrest according to pulselessness, CPR, or defibrillation needing to be performed. And then we did content analysis on these transcriptions of these calls. And we then basically found these descriptors of the patient's condition inductively and started profiling that. Importantly, though, is that the descriptors that we use are not in response to a question. So if we look at out-of-hospital cardiac arrest, it's not in response to the call taker saying, does the patient have a pulse? It is how the caller spontaneously offers the information. This normally happens in the initial part of the telephone call, where the person would answer the phone and say, emergency medical services, what is your emergency, or what is happening there, or so on. And then the person would launch into offering the this information. So in myocardial infarction in particular, we see that 88% of callers described it in heart-related descriptors. Interestingly, 1 in 5 reported having no pain. 16% reported chest-related results of pain. Others spoke about mobility problems, and others, 8% of so, described difficulty in breathing. So 88% of the calls were sort of made up of that lexicon. In sepsis, we found that 86% of callers actually described gastrointestinal symptoms or acute altered mental status, weakness of the legs, interesting, and malaise. And in out-of-hospital cardiac arrest, we found that 71% of callers described medical history or suspected diagnosis, oftentimes talking about they think the person is having a heart attack. And about 1 in 5, 18% or so, they spoke about level of consciousness, and oftentimes pulselessness or suspected death. So just one thing around the out-of-hospital cardiac arrest descriptors of suspected death. What we're wanting to look at in the future is to see whether specifically out-of-hospital cardiac arrest is a priority response because someone is pulseless and seconds could influence the survival of that person. But at baseline, mortality is very, very, very high. And so we need to try and find a way, potentially, where prognosis can be teased out. And we're trying to see whether if someone definitively describes someone as, I think this person is dead, whether that actually has an influence or could predict good prognosis or bad prognosis. So these are just signals that we're seeing by using these qualitative content analysis processes. So watch this space. We'll work on that going forward. Then there's, and importantly though, in all of these instances, these are in different languages that we actually end up merging the different language descriptors and finding that it's actually, while different words are used, the content of the meaning of what is being said is often quite the same. And then, of course, we thought, okay, well, let's look at the private sector specifically for out-of-hospital cardiac arrest very recently. And we wanted to sort of test whether people in the private sector speak differently than people in the public sector, because we always say, oh no, public sector is not transferable to private sector and vice versa. But here we found very similar results, which probably says to us that there's a chance that that we could probably develop universal, outside of language and outside of sector, universal triage algorithms going forward. Then we also looked at stroke. In this case, not how people describe the stroke, but rather at the accuracy with which the implementation of the Newcastle FASC stroke assessment can actually identify stroke diagnosis on the scene. And we found quite a modest sensitivity of 87.5%, lowish specificity, and then you can see the predictive values. But this shows us that this might be helpful as a screening tool for stroke. But while the performance was very, very good, only about 43%, only about half of times was the assessment actually applied to the call. So that made us wonder what could be the reasons why we are not actually seeing why people are not applying this very successfully. So we found that some of the barriers to using this was a little bit about practicality. So there were language problems, there was issues with proximity of the caller to the patient, or the patient was actually unconscious, or because of the technologies used, or because of maybe telephone signal, there was issues with hearing. Interestingly, which I did not expect, is that emotionality came up quite often. In particular, when we found that there was displays of lack of empathy of the caller to the call taker, this resulted in the communication breaking down completely, and often in frustration on the caller's side when trying to communicate with the call taker, to the point where oftentimes it would result in profanity. Well, oftentimes this was a qualitative study, not a quantitative study. So oftentimes I should probably not even be using if I want to be purist qualitative in this regard. But it results in profanity in many instances, and that really affects the ease with which the communication can continue, and that also prolongs the call time and the conversation between the caller and the call taker, which has implications both in terms of delaying an ambulance response, but also occupying a line for a longer time, meaning the next caller actually has to wait longer potentially before they can actually be helped. And then, of course, knowledge and understanding we found were also barriers to this, especially in the form of almost like an anchoring bias, where someone offers what could be wrong, what are the signs, but this might not actually be accurate, or where the signs are already spontaneously offered to the call taker who then doesn't even bother to do the fast assessment because the signs have already been offered. And then other facilitators to using it was if there was cooperation and very clear instructions to this, and managing the emotionality of the caller. So given this lack of accuracy and the idea that things are not actually transferable, as well as these descriptives that we've used or that we've found, we developed a and this also shows us that the accuracy of what we're doing is not only as good as the tool, but also in how it is applied. So that has a very strong signal towards needing to ensure that the implementation of this and the training associated with implementing these triage tools is actually just as important as having an accurate telephonic triage tool. So what we then did is we've developed this approach that we are slowly but surely using to develop these algorithms and to bolster them. So what do? Well, firstly, we need to understand the context. That's the socio-linguistic context, socio-demographic context, and the context of the burden of disease and what is actually important and priority areas to look at. This also is, understanding the context is also important in looking at those that are most inaccurate at the moment to see where we need to focus our efforts on building algorithms. Then we look at the qualitative descriptors that kind of enters using latent and manifest content analysis to find out what descriptors would trigger you to open up a particular triage tool based on the descriptors that the participant or that the caller is providing. Then we look at quantitative variables that could be predictive of the eventual outcome, like, for instance, risk factors. So, it's unlikely that a 22-year-old would have a STEMI, but if it's more of a 50, 60-year-old, those quantitative variables that we can gather over the telephone could help us improve accuracy. And we are currently busy with this in looking at abdominal pain and finding a low acuity triage algorithm using that quantitative variable approach. Then we build the algorithm, often through sort of classification trees like chi-square automatic interaction detection, or if you want to be a bit more fancy, you can use machine learning like random forest classification trees or so on. Then you've built the algorithm. You then test it for accuracy, either through simulation, so running through it on other calls, or you can actually put it into production and determine the accuracy. We then refine it to make it more accurate through negative case analysis. So what was different in this case when you versus what was different from this case than what your standard algorithm looks at that missed the accuracy of this triage process. And then lastly, through training, coaching, and quality improvement, bringing in education, empathy training, and so on, to continuously refine and ensure that the implementation process is improved. So this is sort of the model that we are using and will use, hopefully, to continue building on this work going forward. But of course, this work has not been without challenges. So we're having some trouble with buy-in from services to actually adopt some of the algorithms and to be able to utilize them. The dispatch systems are often quite inflexible. So if a dispatch system is not set up to accept an algorithm like that, or questioning or so on, you can't actually implement it. We have quite a big problem with data linkage to final outcome. So it's hard for us to link for instance, the MI patient that was diagnosed on scene with the patient's eventual admission or discharge diagnosis from hospital, unless it's a manual process. So you can imagine if you want to scale, that would be a bit of a problem. There's currently very limited training for call takers and dispatchers, and there's also no unit standard that is applied from a SAC or NQF level for emergency call takers or dispatchers. And there's no, as far as I know, current curriculum that can be used as a unit standard for this. So I have a PhD student who's currently working on developing a national curriculum to ensure that we have this and that it can be applied going forward, because that's also important, as we've seen in some of the work that we've done. We also have a problem with sample sizes. So we are, this is very manual, and you have to sort of manually transcribe for the most part, because transcription software that is available commercially and uses AI does not recognize all South African accents. Even if they speak English, it's very inaccurate, and they're mostly based on like American accents or British accents. So it's still a very manual process, but we've successfully been able to use machine learning to make new data sets from existing data sets, and we've been able to increase our sample size of 71 to about 1,100 using machine learning. And then in the same study, we were able to find that in the newly generated samples, machine learning was able to classify cases from transcriptions with 95 to 100% accuracy in out-of-hospital cardiac arrest, sepsis, stroke, and myocardial infarction. So there seems to be some more developments in the machine learning space that we can utilize to improve accuracy. And in many international spaces, there's machine learning that listens in real time to the call and then makes suggestions on what's happening. So again, our systems can't always support that, but that's a space where we can maybe move into going forward. So what's some of our ongoing work? As I said, we are developing a low acuity dispatch algorithm to minimize over triage. And the same PhD student that I spoke about earlier has provided sort of consensus criteria for what low acuity could look like through a Delphi process across 20 call types or chief complaints. And he's, as I said, currently developing an algorithm using this process on abdominal complaints, which we saw had about 75% over triage rate. And then we're also looking at developing telephonic CPR algorithms to ensure that there's bystander action. This has implications also on other bystander interventions, such as bleeding control and so on. But we currently in peer review found that while CPR is offered to about 83% of cases, it's only initiated in 35% of cases. And numerous barriers actually exist, including, once again, lack of empathy and support of the caller, but others included, again, poor communication, caller uncertainty and emotionality and practical barriers. So we're starting to see the same things occurring in many different places and in many different call categories. And then lastly, we need to think about disability inclusivity and how sort of the deaf community and those with hearing or speech impairment, how do those people access emergency care if we are going to, in order to ensure that our algorithms are also disability inclusive. But I know some of the private sector spaces have created sort of video apps where there's South African Sign Language on and so on. But of course, we also know that SASL is not universally taught, and often the type of sign language that many people are using is actually very much circumscribed to the community in which they live, and the language originated within that community and is not necessarily the SASL as it is written. So that was really just a quick whirlwind through the work we've been doing in the last couple of years, and that these are also the this is sort of still an ongoing project that we're really well, that I'm really passionate about, and that I hope that you found this interesting, and that you, yeah, I'm happy to take any questions now. Thank you.
Thank you, Willem. That was very informative. Are there any questions? You can put up your hand or even put it in the chat. We'll monitor it. Willem, I think while they are pondering about questions, perhaps a question from my side. When it comes to scarce resources, I always ask myself the question, what is the ideal cutoff or playoff between sensitivity and specificity? What are we trying to achieve? So if we want to not miss anything and pick up everything, then we're aiming for high sensitivity, but that doesn't necessarily impact resources. It may actually increase the resource utilization. If you want something that's a little bit more specific, you made an example, you want to decrease the over triage. I would imagine that it would be you're aiming for a higher specificity. I mean, I may get a bit technical, but can you talk us through your
Yep.
through the goals? Yeah.
Yeah, I think it's important to take the risk involved when you're looking at every particular chief complaint that gets spoken over the telephone. So, for instance, if the opportunity for early intervention is quite high and it has a massive impact on on outcome, then you want to be you might want to rather err on over triage, because then you will respond to everyone and you will want to maximize what you can potentially do. So it really changes based on the risk that you're seeing with that particular case and that particular patient. And for that reason, you might want to, certain algorithms, you might want to maximize your ability to screen patients out, and others you might want to maximize your ability to move patients in. So it really depends on all of those factors so that you can decide what is the balance between the risk to the patient and the risk to the system. So maybe you thought I had a much more specific or sensitive answer to your question, but it really changes based on what we're dealing with the risk pattern, and with that particular case. And of course, what's also relevant there is maybe the utilization for those particular presentations. So if you have lots and lots and lots of those cases coming in, you might want to take a different approach to ensure that at the back end, your resources are not burning. But I think it's for this reason that we can't just always transplant something from elsewhere into our systems. We need to really think about it and be a bit more deliberate when we're developing this. And I think, and I'm not trying to secure my own job by saying that it's probably for that reason why we need to think about developing this specifically for our contexts, versus just transplanting something from somewhere else. Sorry, I didn't purposefully try to evade your question, but I just wanted to illustrate the complexity that goes on in my head when I think about your question.
Leandra had a question. I think, Leandra, you put your hand down again, but you still have a question to ask? Seems to have gone away.
Yeah, good morning all. No, I don't have a question. I'm just quite happy that you're focusing on the dispatching and the call taking of the calls, because sometimes calls can be wrongly captured and we are sent to calls, like you mentioned, over triaging and under triaging. So I'm quite happy about the algorithm. It will make things a lot easier on the road. Thank you.
Thank you. And that's really what we're trying to do, is we're trying to match the need of the patient to the response that we send them to maximize outcome, but balance resources. And at the same time, we also just need to think about, you can have You can interrogate a caller for 25 minutes and get the most accurate response or the most accurate answer. You can be correct 100% of the time. But you also need to balance how long you keep the person on the line, both in terms of delaying dispatch, but also in terms of, burning the queue of incoming calls. So there's that balance that you also need to strike in deciding what is most important and what is least important in what you need to ask. Yeah, and I'm resisting the urge to be very technical about how the chi-square interaction analysis works, but I'm not going to do that now. We can deal with that another day because it is quite technical, but it's very helpful because it tells you what's more important, and it has the bigger influence on your accuracy, which I think is pretty grand. Yeah.
Willem, I've got another question. Considering the fiscal crisis or the fiscal state we are in, let me rather call it, because it's not temporary. It's a new fiscal state. What role do you think this may have in the upcoming years, from a cost-saving point of view, etc., etc.?
Yes, a very important role, I would say. So the thing is, when you have limited healthcare funding to respond to patients, and limited resources, unfortunately or fortunately, the only way to improve that situation is to be more efficient and more deliberate in what you do, because otherwise people will suffer at the end of the day, and patients, especially in the space of emergency care. And I maybe just want to, while I'm formulating my answer, I want to just be crystal clear that I accept that there are people who do not have necessarily a traditional emergency presentation, who have no choice but to utilize the emergency medical service for access to care, whether that is going to the emergency department via private transport, or whether that is to phone for an ambulance. So I just want to put that there. I do acknowledge that, and I acknowledge that that is an important part of how people access care. Whether that is the best way to do it is something for another discussion, but I do acknowledge that. Now, the only way to then improve efficiency is to make sure that you are maximally optimizing the resources of its intent, which in this case would be emergency medical services and out-of-hospital emergency care, to the need of the patient. Now, you can't, if you only establish the need of the patient when you get there, you have already kind of missed the boat, because you're already expending your resource in order to, you're already expending your resource, and then you get there, and then maybe you find out that this is a different kind of case, and notwithstanding that you will have cases waiting. So this process of triaging cases accurately at the point of where the care is sought, which is the dispatch center, is essential in maximizing or optimizing the use of the limited resources that we have available, and minimizing risk to not having a response and then having a bad outcome at the end of the day with certain patient populations. So yes, essential.
Thanks, Willem. Khaled, you can go ahead.
You can go ahead with your question, Khaled.
Can you hear me? Hello, can you hear me?
Yes, I can hear you. Yes, go ahead.
First of all, it's very interesting meeting to listen to such a new research and new thinking of developing EMS all over. And I have one question came to my mind when you are coming to develop a telephonic triage tool, and is that triage tool, how we can measure it and how we can say it's a valid and reliable triage tool? So how we can validate and validate that I mean, so for example, do we will use something like called inter-rater reliability to validate and rehabilitate this tool?
Yes. So the first is you have to kind of ask, what are you trying to predict accurately? And in this case, what we've mostly done is we've looked at the actual outcome, which is yes, this is myocardial infarction, or no, it is not. And what we've also looked at is triage at the point of the call versus eventual triage on the roadside using South African triage scale. So then we just use standard accuracy measures like sensitivity, specificity, and so on, and also over and under triage rates to understand risk versus resource wastage. So that's number one. And then you have the tool. And now when you're implementing the tool, you need to make sure that, and that would sort of deal with its validity parts. And that would sort of be internal validity and accuracy. And then when you implement it, you need to make sure that your call takers, who are hopefully trained and empathetic, as an example, that they then apply this in a reliable way, so repeatability. And that's where you look at inter-rater and intra-rater reliability. So that comes at the point where the tool's developed, you're happy that it's pretty accurate, and now you try and see whether it's going to be the same for different people doing it. And there you can also look at between different professional groups, depending on who you have taking the call, and so on and so on and so on. And then we think about external validity or transferability to other contexts. And based on my argument earlier, I don't think we can always do that as specifically, not specifically now, talking diagnostic accuracy, as willy-nilly, so to speak, as what we think we might be able to. I hope that answered your question.
Yeah, very clear. Thank you so much.
Perfect. Thank you. Good.
Jeroen, I think we've probably reached our time limit.
Yes. I think we've had a great interaction and some interesting questions, and I think we can probably wrap it at that point.
Yep.
Sorry, there we go, my camera on as well. Thanks everybody, and thank you, Willem, for the great talk and interesting info on this process. And thanks to everybody for attending.
Thanks, everyone. Happy to take any questions via my email if you want to, and don't forget to send for CPD.
Yeah, I've received a number of people already who've emailed me. So, and just then a quick reminder, the next seminar is on the 14th, sorry, on the 24th of this month. Dr. Renee Krauss will be presenting a talk on palliative care, on a reflection on palliative care integration strategies. So our next seminar is the 24th of October, and we'll be sending out invites in the next couple of days.
Great. Thanks, everyone. Have a good day.
Thanks, everybody.
Cheers.
Bye-bye.